Hello, everybody. This is a video lecture for Chapter 21 for microbiology, the second video lecture for March 17th. And today we will be talking about the respiratory system, which is why we're all on lockdown right now, which, well, we're actually not on lockdown. Don't quote me, that's not happened yet. But the biggest thing that we're facing right now is issues with the coronavirus and COVID-19. And so anyhow, I thought it would be timely to talk about respiratory diseases, including viral diseases like the coronavirus. Okay, so our objectives are to discuss the defenses, for the respiratory system. We'll talk about what grows there normally, and we're going to split things into the upper respiratory tract and the infections that you find there, as well as a lower respiratory tract and the infections that you find there. So a little anatomy for you. This just shows the sinuses working down to the tonsils and your nose, your nasal cavity and your nostrils, your mouth, your pharynx, which is more for breathing, and then your trachea, your epiglottis, and then working down to your lungs, you have bronchial tubes, and then in the bronchioles themselves, the smaller like bronchial capillaries, then you have structures called alveoli, okay, in your lungs. So some of the defenses, cilia and nasal hair. The cilia line the respiratory system, and nasal hair then keep things from going up your nose through the respiratory system. Mucus and the mucous membranes makes the membranes in your respiratory system slippery. Coughing, sneezing, and swallowing are just defense mechanisms in order to dislodge foreign pathogens. Complement action, the complement cascade is highly active, and an increased level of cytokines and antimicrobial peptides specifically around your respiratory tree. Macrophages in the alveoli and the lymphoid tissue in the throat. So, which are resident macrophages. Remember, macrophages only last short term, but they're continually replenished. And then the whole thing is lined with secretory IgA, the type of antibody that is secreted and coats membranes like mucous membranes in the respiratory system. Okay, your normal biota. You have a lot of different bacteria. This is not a sterile system, so you'll find bacteria in the upper and the lower respiratory tract. And these resident biota are important to monitor compromised individuals because they can still cause disease. Things that you would think normally would be disease causing can cause disease when they're out of check, like Streptococcus pyogenes, Haemophilus influenza, Streptococcus pneumoniae, Neisseria meningitidis, and Staph aureus. So these are normally there, even Staph aureus in carriers, but when they become out of check, that's when you can become infected. Okay, upper respiratory infection. Let's just talk about the common cold. So we'll just jump into diseases right away. This is often called rhinitis, and rhinitis includes, like your nose, rhino, sneezing, scratchy throat, runny nose. And it's, most of the time when you have a cold, you may run low grade, but generally you're not feverish. and what we call colds, which come from rhinovirus. There's 200 different types of colds. One of the reasons why there isn't a vaccine against the common cold, because there are just too many viruses that cause that, and also it's generally very mild, very short term. Respiratory syncytial virus. You hear RSV, especially in newborns and premature infants. There's a real concern about RSV, and but these can also cause colds, but they can lead to more serious symptoms. And these types of infections, they're minor viral infections, can lead to secondary bacterial infections. And the symptoms that you feel, the swelling and inflammation of mucous membranes in the nose, leakage of fluids, so you've got runny nose, watery eyes, productive cough, increased production of mucus. These are just your immune system fighting back. It's not, the types of symptoms that you feel aren't necessarily from virus damage. It's just from your immune system getting rid of the virus. Transmission by droplet contact. So you can exchange droplets through not covering your cough or sneeze, through talking. You can also get droplets on your hands and exchange these by fomites. And since there's so many different varieties of colds and cold viruses, then it's not like something like the chickenpox or the measles where you get it once and you're immune. So because there's just such a wide variety of viruses, yes, a cold will give you immunity to that type of virus, but you are susceptible to getting infected by different types of cold viruses. And the best prevention is just keeping transmission down. And treatment there is no real treatment for the common cold. You can use zinc lozenges, even homeopathic zinc. Zinc decreases the duration of the cold by blocking replication of the rhinovirus, and so this is for symptoms only. Sinusitis is any type of inflammatory condition of the sinuses in the skull. It can be bacterial, it can be viral, it can also be fungal. And fluid and mucus trapped in the sinuses just through inflammation and just blocking the sinus passages provide growth medium for bacteria and fungi that are already there. Okay, and so you get a lot of nasal congestion, a lot of pressure in the sinuses, headache, and sometimes because the location of the sinus is close to your teeth, it can feel like a toothache. And if you have a bacterial infection, then the mucus from the nose or in the mouth is opaque. And they always ask you the color of the mucus when you have some type of sinus infection, because if it's running clear, it's probably viral, but if it's green or yellow, then it's bacterial. The viral agents for sinusitis is the same as the common cold, most commonly rhinovirus. And the bacterial agents are the primarily resident microbiota in your respiratory system, like pneumonia, Pyogenes, Staphylococcus aureus, more rarely Corneabacterium tuberculostiricum, and Haemophilus influenzae. Fungal infections are more rare. You can get this like if you wear a sleep machine or a CPAP though, because they notoriously grow fungus. Things like Aspergillus and Bipolaris. And here is our wonderful table for sinusitis. And this shows the different modes of transmission. For viruses, these are not endogenous, but for bacterial infections, they're mostly endogenous or opportunistic infections. And fungi can be introduced by trauma, just where the nasal passages are injured, or just through opportunistic overgrowth. For viral sinusitis, usually you look at clinical presentation. For bacterial sinusitis, same thing, you're looking at the color of the mucus. Occasionally, if you're looking for blocked sinuses, then you'll look at x-rays. And also the same for fungus. Best prevention for these is hygiene. Okay. However, when you have an endogenous infection, it just could be the possibility that you're being run down, and things that are normally in your sinuses then start to overgrow. Okay. For viral sinusitis, there is no treatment. Okay. For bacterial and fungal infections, there are antibiotics and antifungals respectively. Sometimes you'll do like a lavage, and you'll rinse out the sinuses to physically remove the fungus. Okay. And epidemiological features, bacterial sinusitis is pretty prevalent, so you get between 12 to 30 million diagnoses per year in the United States alone. And then fungal sinusitis is more regional. Okay. Otitis media is just another name for ear infection. And this is a common sequela. Remember sequela or sequela of, it just means that it's a disease that follows. And so this is a disease that follows a common cold. When your system gets run down from the cold, then that can lead to an ear infection. The eustachian tubes in the ear will block and lead to a buildup of fluid behind the ears that can lead to, makes a great medium for bacteria. They're resident in there to multiply. And so you'll start to get more bacteria propagating, and this will turn on the immune system to engage in inflammatory response, and this is called effusion. Let me make this big. Oh, okay. So symptoms: fullness behind the ear. It's like you have a sinus infection behind your ear, and pain in the ear, and also muffled hearing. It can lead to rupture of the eardrum if not treated. In some countries, they allow the eardrum to rupture, and that causes effusion. In other instances, individuals will get PT tubes or ear tubes to allow normal flow of any type of pus and effusion out of the eardrum. Okay. And the main causative agents are Streptococcus pneumoniae, Haemophilus influenza, and then you can have a mixed infection that could start as a virus and then hasten a bacterial infection. Ear infections are not communicable, so you can't touch somebody's ear and then touch your ear and then get an ear infection because they're endogenous infections mostly. Okay, and then treat with some type of broad spectrum antibiotic, and you just watch and wait. Okay, and you see, here's the outer ear, here's the middle ear, and here's the inner ear, and here's the eustachian tubes, and the eustachian tubes that are inflamed and blocked. This allows fluid to collect behind the ear, and that fluid then becomes infected with bacteria, resident bacteria. The eardrum starts to bulge, and the eustachian tube initially is inflamed and it remains to be inflamed. And once the inflammation goes down here, then that exudate could flow out. but typically with a bacterial infection, then in the United States, an antibiotic is prescribed, a broad spectrum antibiotic, in order to clear up the infection. Okay, here's our nifty chart. As you can see, Streptococcus pneumoniae and Influenza are endogenous. Both of these are capsular bacteria. Haemophilus influenzae has fimbria, so it can form biofilms. And Streptococcus pneumoniae has hemolysin, so it can break down red blood cells. And I'll show you this in a lab that's coming up. We have an agar plate that has sheep's blood in it. And with that sheep's blood, Streptococcus pneumoniae will lyse the red blood cells, and you can actually see it clearing where the red blood cells used to be, and the media then becomes translucent. This usually resolves itself if it is bacterial or viral, but if it doesn't resolve itself within 72 hours, then you may get a further diagnosis, go to the doctor. Same with Haemophilus influenzae, as well as other bacteria and viruses. The pneumococcal conjugate vaccine does provide some protection. However, Streptococcus pneumoniae, there are many different strains, and the pneumococcal vaccine only protects against a few of those strains. So it's not exactly the best vaccine ever. It's only heptavalent. It means that it protects against 7 different strains of pneumococcus. And so that means that there are many other strains that can also cause problems. Same with the Hib vaccine. This is a vaccine that's given in childhood, and with limited success. It doesn't seem to curtail ear infections, whether they're Hib or not. A lot of times, diagnoses are not necessarily made at that level. So a lot of ear infections occur, and you don't know whether it's Streptococcus pneumoniae or Haemophilus influenzae. Amoxicillin. And amoxicillin plus clavulanate, which is clavulanic acid, that is basically augmentin, and this makes amoxicillin resistant to penicillinase, and so it will bypass bacteria that have penicillin resistance. And cefuroximine is rare. I don't know as much about that. Same for Hib. In terms of other bacteria viruses, that you might use something like azithromycin, which is also called a Z-Pak. But azithromycin has a lot of bacteria have adapted to the Z-Pak because it's been so popular, so easy to use. They only take it 5 days, and so medical providers aren't necessarily prescribing the Z-Pak as much any longer. Okay. Distinct features. Other bacteria and viruses, a lot of times practitioners will disregard vaccination status if you have an ear infection and then just give you a broad spectrum antibiotic. So I've never seen this really come into play. It's very prevalent. 70% of the children in the United States have experienced an ear infection by age 2. It can lead to hearing loss if it goes untreated. And so without treatment, without antibiotics, then this can be a real problem. Okay. Next, we have pharyngitis. Pharyngitis is just a sore throat that your pharynx is inflamed. The mucosa, the mucous membranes are reddened, your tonsils are swollen, and you can actually see inflammation and little packets of inflamed products. Sometimes these are called encapsulated infections. Encapsulated infections cause really bad breath, and mucous membranes also may be swollen, but definitely you see a lot of reddening or erythema. Okay, this is how they look. You can see some little pockets here where pus is getting filled up, a lot of swelling of the uvula, and definitely erythema, redness. Okay. This can be caused by Streptococcus pyogenes, which is an endogenous infection. And you want to get strep treated. This can lead to scarlet fever if the pyogenes is infected with a particular phage. This also can lead to rheumatic fever, which is an autoimmune response, as well as glomerulonephritis, which is a liver disease. It's also autoimmune. And this is specifically because the Streptococcus M protein on the surface of Streptococcus looks a lot like proteins in the body, and that will raise up an autoimmune response. Okay. Bacterial surface antigens, like I said, resemble heart, joint, and brain proteins, and so this can be really, really complicated. This is called molecular mimicry, and where one protein in nature is very, very close to the other protein, and then all of a sudden you're raising up a response or an autoimmune response. This can also cause what's called PANS or PANDAS, pediatric autoimmune neuropsychiatric disorder associated with streptococcus. And you see this with children, and what happens is when they get a strep infection, then they show a lot of signs and symptoms of things like autism. They get increased anxiety, increased phobias, repetitive behaviors, things like that. And so long-term antibiotics can be used for this. Okay. Scarlet fever is another complication to strep throat or pharyngitis. And this is when Streptococcus pyogenes, the specific infection, is also infected with a lysogenic phage, and this produces what's called an erythrogenic toxin. This becomes systemic, and then it spreads to the skin, and you get this rash on your neck, chest, elbows, inner surface of the thighs. It's papular, meaning that it's raised. Remember papules. Also get a high fever. That's why it's called scarlet fever. And the rash, a lot of erythema, so it's a red rash. That's why they call it scarlet fever. It is fairly mild today. Pyogenes can be treated with antibiotics. Here's scarlet fever. I'm not sure what the arrows mean. I got this off the internet, but you see the scarlet appearance of the cheeks. Rheumatic fever. And this is, it's been fairly established that this is immunologic cross-reactivity between the streptococcal M protein and the heart muscle. Okay, this can lead to a weakened heart, permanent damage to the heart valve. My grandmother had rheumatic fever, and when rheumatic fever occurs, then the weakened heart, then she ended up passing away when she was about 65 because her heart was just so weak. Also can lead to arthritis because the streptococcal M protein looks a lot like the protein in the joint. Okay, and here is just a normal view of a mitral valve up top, and then second, you can see a scarred mitral valve, and you can see where this would lead to improper closure and improper blood flow. Okay, the color difference, artificial, completely artificial. So it has nothing to do with blanching of the tissues. It's just the scar tissue that you see in the mitral valve. Glomerulonephritis, again, a liver disease. This is a type 3 autoimmune reaction. And it is these antigen-antibody complexes. That antigens are surface antigens from the liver. They deposit in the basement membrane, kidney, not liver, of the glomeruli of the kidney. You see swelling of the hands and feet, blood in the urine, because of compromised abilities of the kidney, increased blood pressure, again, because the kidney isn't functioning, as well as heart failure. And glomerulonephritis can lead to permanent kidney damage. It is transient, but it can cause permanent problems. Streptococcus pyogenes virulence factors, including surface. I believe, yeah, this is a lipid lipoic acid, fatty acid that allows the cells. It's sticky, so the cells can stick to the surface of the pharynx. The M protein on the surface causes pyogenes not to be able to phagocytize. Streptolysin causes a type of hemolysis called beta hemolysis, and it can rapidly injure many blood cells, okay, and other cells as well. Erythrogenic toxin, erythrogenic, whenever you think erythrocytes, or you see sort of redness, a bright red rash, and a fever. And streptolysin and erythrogenic toxin can lead to what's called a cytokine storm. They can act as super antigens, and so you get T lymphocyte reactions as well as monocyte reactions, and the reaction itself in the inflammatory response does more damage than the pathogen. Okay, in terms of transmission, it's about 30% of all sore throats. It's very similar to coronavirus, respiratory droplets, contact with mucus secretion, fomites, and carriers. Not as likely. You don't get non-infected carriers very much. Okay, fomites less frequent, but again with droplets is much more frequent. Okay, and in terms of trying to vaccinate against this, there's a lot of different types of Streptococcus pyogenes, and you would have to have a specific antibody for each type, and so it makes it very difficult to come up with a, compared to the pneumococcal vaccine, this would be much more difficult. You can do a rapid strep test. If you've ever had strep throat, you probably did a rapid test. This can give you false negatives if you, depending on what your load is of bacteria, and so they will always culture these. They culture with blood agar, usually sheep's blood agar, and they look for characteristic beta hemolysis. And they'll also use antibiotic tests, which I will be demonstrating after spring break, to show positive bacitracin resistance. Okay, so you just take an antibiotic disc, put it on a Kirby-Bauer plate, do a Kirby-Bauer test, and then you see, do you have strep pyogenes resisting the bacitracin? So it actually grows closer to the disc because it is not susceptible to bacitracin. Prevention, again, because there are 80 different serotypes, it's very difficult to develop a vaccine. The standard treatment is with penicillin, cephalexin, in patients with penicillin allergies. Another type of bacterium is Fusobacterium necrophorum, excuse me. This causes serious pharyngitis. It can become systemic, and it's very susceptible to broad spectrum antibiotic, and it causes maybe 10 to 30% of all sore throats. Okay, you can gram stain this. It is gram negative, where I believe, let me check the next slide, has an odd morphology, and that will show that it's not Streptococcus pyogenes. Okay. And then the alternative would be a viral form. And usually the goal is to rule out Streptococcus pyogenes. Fusobacterium is not as common. Okay. And if you look at the epidemiological features, um, about 40 to 60% of all pharyngitis is viral and not bacterial. So with viral forms of pharyngitis, then there would be no treatment, but you would have just different lozenges that don't contain antibiotic that would be ineffective, and so you just relieve the symptoms, the pain, any discomfort, any fever, and let the viral infection run its course. Diphtheria. Next, we talk about diphtheria, and this is a disease that you don't really hear that much anymore. If you get the DTaP vaccine or the Tdap vaccine, the D is the diphtheria antigen that you're being vaccinated for. And there's been a significant decline in cases due both to vaccination and sanitation. No cases have really been reported in the United States since 2003. Although there are a significant number of carriers of Corneabacterium, sorry, that's misspelled, diphtheria A, but they're asymptomatic, okay? And this is through direct contact or fomites. There's a diphtheria toxin, and this is sort of a gray, black colony. Kind of the morphology is a club shape, and this can be a part of the DTaP, the Tdap, or the TD vaccine. And if you do get it, then usually you're given diphtheria antitoxin, which is, I believe, is an antibody therapeutic, and then penicillin or erythromycin. So you need this is bacterial, so you do need an antibiotic to prevent spread of the disease. And like I said, no cases in the United States. Internationally, it's very rare. Even though there's 83% vaccine coverage, you can see that that the disease has been nearly eradicated worldwide. Okay, whooping cough. It's also called pertussis. The prevalence is currently increasing in the United States, despite near 95% vaccine coverage and vaccination rate. The incubation period is anywhere from 3 to 21 days. And in the catarrhal stage, that's the very early stage of bacteria in the respiratory tract, give you cold-like symptoms. Okay, in the paroxysmal stage, which is later, is this uncontrollable sort of whooping like cough. And it's a very distinctive cough. It is really debilitating. It's really debilitating for infants. Okay. The causative agent, this is why it's called pertussis. The bacteria is called Bordetella pertussis. It's a small gram-negative rod. And the bacteria has adhesive molecules like filamentous hemagglutinin, and it firmly adheres to the throat, so it's difficult to cough out. And the bacteria then produce an exotoxin, and that causes the skin cells, or the mucous membrane cells, epithelial cells, damage, and that also cripples components of host defense. Many adaptations to survive. Okay. And the coughing is caused by a cytotoxin that just basically destroys ciliated cells. All of the epithelial cells in your respiratory tract are ciliated, and the cells are no longer able to clear mucus, so you just cough and cough and cough, and it's very, very unproductive and it's dysfunctional, and so you cough to get rid of the mucus, but the mucus is not coughed up. Okay, and so you get excessive coughing to clear the mucus. The mucus is ineffective, and then the coughing continues. Okay. In terms of numbers of reported cases of DTP, this or of pertussis, this is when the DTP vaccine was introduced. The DTP vaccine was effective in reducing pertussis cases. However, it had nasty side effects. Many people died. Many people were damaged neurologically. Many people developed seizure disorders because of the pertussis toxin. Okay, because of the pertussis cell. DTP is what's called a whole cell pertussis vaccine, and it has the entire pertussis cell, and the antigens from the pertussis cell were causing an excessive immune reaction. This was causing damage, and so people were being damaged by the vaccine. The DTaP vaccine was introduced. Actually, this is incorrect. It's 1995, but the DTaP vaccine was around earlier than that. But when it was more used widespread and they phased out the DTP in 1995, then this started an increase in pertussis cases because this AP stands for acellular pertussis, and the acellular pertussis portion is ineffective in preventing pertussis. In some cases, it can actually cause what's called parapertussis. Here's the Tdap vaccine that has a lower dose of acellular pertussis given as a booster shot. And you can see, because this is a less effective vaccine, then the incidence rate in the United States is going up, and it's higher and higher and higher. Okay. It's diagnosed based on symptoms because the cough is really distinctive. You can cultivate for Bordetella pertussis, and the vaccine offers limited protection, and it actually allows people to culture Bordetella parapertussis in their throats without symptoms. And so it's a little difficult, and it's offensive to me. Some of the advertising showing grandparents turning into wolves if they don't have the pertussis vaccine is actually quite opposite. That if you get the vaccine, then you can become an asymptomatic carrier, and your possibility of carrying and spreading the disease becomes much, much higher if you're vaccinated. Okay, simple prophylactic antibiotics can be used if you come into contact with patients to prevent spread. This is azithromycin or Z-Pak. Okay. And here's just our run up on this. Virulence factors are this filamentous hemagglutinin antigen, pertussis toxin, tracheal cytotoxin, which causes the cilia on cells to be destroyed, and endotoxin. Okay. Prevention is caused by it can, it's putatively allowed by acellular vaccines, but again, you have to take that with a grain of salt, because with the acellular pertussis vaccine, we're seeing an increase in pertussis cases. If you come into contact with somebody that has pertussis or whooping cough, then you can take azithromycin. If you get whooping cough, you can also take azithromycin. And the cases in the United States in 2012, this needs to be updated, more than 40,000, so it's on the rise, and about 140,000 internationally. Okay, RSV is respiratory syncytial virus. Okay, and this is a viral infection, and it produces syncytia. Remember, those are the structures where you get multiple human cells fused together, and they are dysfunctional. They have multiple nuclei. This is really common in neonates as well as preemies, especially preemies. And this can result in about 100,000 hospitalizations per year. Fever, rhinitis, runny nose, sore throat, and ear infection, or an affected ear, redness of the ear. And this is the main causative agent of croup. You know, we hear about croup, but this is RSV leads to croup. Okay, and it gets transmitted by droplets and fomites. You have to be very, very careful with preemies and newborns because the mortality rates can be 3 to 5% in preemies or those developed with congenital heart defects. And in developing countries, the RSV or croup has a much, much higher mortality. Flu, okay, influenza. This is a virus that circulates every year, and they're called seasonal flus. You can get a flu out of season, but they do circulate more commonly in the fall, winter, and spring. Okay, and occasionally there's other strains that are more pandemic strains like swine flu. Okay, H1N1 caused a pandemic flu in 2009 to 2010, actually a much larger pandemic than we're experiencing right now with coronavirus. And it's an envelope protein, or an envelope virus with a matrix protein below the envelope. It's a negative sense RNA virus, and then in the envelope there are little ion channels, and these ion channels then allow directly the exchange of things like sodium and potassium. There are coat proteins these are like glycoprotein spikes called hemagglutinin and neuraminidase. Neuraminidase. Yeah, I always said that right. Okay. And then the membrane, of course, comes from the host cell that has been invaded. Okay. You have upper respiratory tract infection, and in severe cases, it can affect the lower respiratory tract. It incubates in 1 to 4 days, and influenza is less common than you probably think. People will get a mild respiratory virus that's usually an adenovirus, and they'll call it the flu. But it's not as common as you may think, and there is a test for influenza. You can do a PCR test on it and confirm that it is influenza and what strain of influenza it is. During your actively invasive period, headache, chills, dry cough, body aches, fever, stuffy nose, sore throat, you're tired, very, very extreme fatigue, and this can lead to bacterial infections as well. Okay. H1N1 was a little different, swine flu, and it caused fever, or did not cause fever, and caused people gastrointestinal symptoms. So they were throwing up and had diarrhea at the same time of having these other influenza symptoms. Okay. There are 3 different types of influenza viruses. There are many, many different classifications below these types. And the reason why you hear H and N associated with flu is because of the glycoprotein spikes. H stands for hemagglutinin, N stands for neuraminidase. Hemagglutinin causes cells to agglutinate or clump. Neuraminidase breaks down the mucus tract, mucus coating that affects the respiratory tract, so it can access the mucous membrane epithelial tissue, and it really mutates very, very quickly. It's known for extreme genetic variability. That's why they're coming out with new flu shots every year, and you can't just get a universal flu shot and be immune to the flu. It will, just due to natural selection and also due to the genetic variability is centered around the cell's immune response. So you can get a different immune response from different types of influenza. You can also get antigenic shift, where different RNA strands between influenza viruses are donated. Okay, and this allows for transmission with animals. This is how you get bird flu and swine flu, is antigenic shift, where different, there are more than one RNA strand, so these RNA strands can be donated. Okay, so you get hybrid strands of flu. And this type of antigenic shift has been traced back to different flu pandemics. There was a bird flu scare because it was so prevalent in birds, and they suspected human transmission. I'm not sure if it ever really was confirmed that there was human transmission, but they had to sacrifice a lot of animals, especially birds and chickens, especially in China, because they were afraid of transmission to humans. And the 2009 pandemic, they saw bird and swine sequences as well as humans. It was known more as the swine flu, but there had been an antigenic shift. Okay, and this is always influenza A. It's not B or C. It has the ability to receive and donate DNA, and that causes a severe problem in terms of with epidemiology. Okay, and so the H and N RNA then can be exchanged. Duck influenza was picked up by pig. Duck did not transmit to human. Human influenza was picked up by pig, and then you got a different strain, and you got human influenza with a duck H spike. Okay, and the virus does bind to ciliated cells, so that would be in the respiratory tree. It strips the layer of cilia, so it can't be cleared. Cilia is important in clearing out viral particles. And then you get a severe reaction of inflammation due to a cytokine storm. And it turns out that young adults with really robust immune responses have the most severe symptoms, because they're fighting off the symptoms that are so associated with the immune system, that when the symptoms occur, that you get this much more severe type of flu. Okay. It also can result in secondary bacterial infections. In terms of transmission, droplets and fomites. You want to avoid crowding and low ventilation, so avoiding crowded areas. And drier conditions allow for the spread, although it spreads really well person to person, regardless of the humidity level. But it does allow for the virus to survive longer outside of a host, and also it provides access to dry and cracked mucous membranes. Okay. And how many people actually die? It's a bit of a mystery. I don't like the way that the CDC reports deaths. They report deaths due to pneumonia and assume that the majority are due to flu. That's not really the case. Okay. It can be tested by a PCR or ELISA. Viral cultures take a while, so 3 to 10 days, in order to cultivate material for diagnosis. Okay, and I don't get the flu shot. You can get the flu shot, that's fine. I am not here to convince you whether to get the flu shot or not, but the facts are that the flu vaccine at best has been reported as 62% effective. This year, the flu vaccine was about 9% effective. And Cochrane Collaboration, which is a prestigious not-for-profit group, doesn't have any ties to the pharmaceutical industry, said that out of every 100 individuals getting the flu shot, only one was gaining any type of benefit. Okay, And if you do get the flu shot, you always want to ask for a preservative-free formulation. You can get this by asking for a single-dose vial because flu shots contain thimerosal. Thimerosal is a molecule that 50% by weight is mercury. Mercury is a neurotoxin, and you get a neurotoxic dose from the flu shot. So if you must get a flu shot, ask for a mercury-free flu shot. Okay. In terms of treatments, there's antivirals. The biggest one is called Tamiflu. Okay. Tamiflu has some side effects as well, neurological symptoms. There's another one called Virulence that is available. I don't know as much about Virulence for that particular influenza drug. Okay. Let's go right to epidemiological features. Cowan says that flu deaths range from about 17,000 to 52,000 in the United States per year. I would say that is more likely 700 to 2,000. Again, she's getting her results. I'm not blaming her. She's getting her results from the CDC, who base influenza deaths based on pneumonia deaths, and they will basically assume that the pneumonia death started out as influenza. That is not the case. So the majority of pneumonia deaths can occur can be caused by different causative agents, not influenza. You can get an adenovirus that leads to a bacterial infection that leads to pneumonia. There are many, many different courses to pneumonia. So to assume that pneumonia and flu are integrally tied and use the same incidence numbers is wrong. So the yearly range is probably from 700 to about 3,000 deaths per year in the United States due to seasonal flu. Okay, and that's the end of this presentation. I'm going to check in on the time. Okay, we're almost at an hour. So we're going to call this good for the second lecture. Second video lecture. I'm actually doing this on Wednesday the 18th, but this is for lecture for Tuesday, March 17th. Next, you will have a lab demonstration. That lab demonstration won't be posted until tomorrow, Thursday, and that will be inoculations for lab 22 and 23. So look for that soon. And also after spring break, we do have an exam. I'm not exactly sure the format of that exam. I can't really give you a timed proper exam online. It's very difficult to do. So it's going to be, unfortunately, a different format, probably an open book and more open question format. I do apologize. I don't like that at all. But I do want to make this as painless as possible for you and make sure that you're prepared and you do get a good study guide. And I have a recorded study session for you as well. I am keeping my office hours right now via Skype. You can reach me via Zoom as well. I will discuss that a little bit more. I'm not sure if everybody has Skype. I'm still trying to figure out Zoom. I'm really a novice with Zoom. But if you do want to set up a time to talk, then please email me and we can talk further regarding microbiology. If you have any questions in laboratory, even if we just talk on the phone, that would probably be helpful in many, many cases. My desk phone is 226-4734, and I am at my desk during my normal office hours. Okay, I hope that's helpful, and we'll talk soon.